The American Rehabilitation Educational Network presents Clinical Update, dedicated to meeting the continuing education needs of rehabilitation and healthcare professionals. Clinical Update is a growing series of informative, useful videotape excerpts from Aaron's monthly video conferences. Applying the talents and expertise of distinguished faculty members from around the world, these programs are specifically designed to provide concise, clinically accurate knowledge for use within the daily practice of physical therapists, occupational therapists, nurses, psychologists, speech pathologists, physicians, and other healthcare professionals. This program, Dysfunction of Trunk Mobility and Control, features Isabel Bowman and Jan Utley.
Bo, it's my understanding that the Bobeth approach is applied primarily to people who've incurred brain damage?
That's right, both children and adults. And, Mrs. Bobeth started with patients that were severely involved with adults, and then moved into working with children, and then went back to working more somewhat with adults. What you're doing when you have a lesion, or the problem with a lesion is that you get abnormal tone, and as a result of this abnormal tone, you also end up having abnormal coordination of movement patterns.
So those are the two givens following a lesion of the kind that we're talking about. Now, this relates not only to the trunk, but to the whole body, but we should be thinking
That's
specifically about the trunk as we're talking about dysfunction now. Okay, will you elaborate for us about tone problems? Give us a quick review of the kinds of things we're dealing with.
Well, there are three categories of tone problems. And as Jan talked about normal postural tone, she described that as a range of tone. And outside of that range, you can be below the range so that you have low tone, which is also called hypotonia, or you can be above that range and have high tone or hypertonia, which is also sometimes described as spasticity or rigidity, and there are several varieties of tone. And there's also another category which we call fluctuating tone, and there are some varieties of that as well, but we like to lump them in those three areas and deal with them accordingly. If the patient has high tone, then we're going to need to decrease their tone and bring it toward the more normal level. Mm-hmm. If they have low tone, we're going to try to bring it up to the more normal level. And if they have fluctuating tone, then we're going to try to help them stabilize and get a co-contraction so that they have stability and can move on that stability.
Now, are tone problems the same wherever they occur?
No, patients very often will have high tone in one area and low tone in another. If you're thinking about the trunk, we've seen several patients that have high tone in their shoulder girdle muscles so that they end up with a retracted shoulder girdle. And they may also have high tone in the limb as well. But they may, at the same time, have low tone in their low trunk so that they sort of sag, and so that they have an asymmetrical trunk. And so you can have a combination of high tone and low tone. Or you may also have high tone in one area and low tone in another area, and you may have, depending upon where the lesion is, you may have some ataxia or other kinds of fluctuating tone as well. So it's possible to have a variety. Usually we have a mix of tone, and it's very rare to have a patient who has all high tone. And if they do start out that way, you may find that as you inhibit that tone, underlying there is low tone.
Okay. Now, how about other elements that contribute to abnormal tone and coordination problems? Jan?
Well, with the lesion, you also have some tonic reflex activity, or what we refer to as abnormal reflexes. Mm-hmm. And I kind of referred to those a few minutes ago with one of the questions. With stroke patients, generally, the ones that are the most predominant are the asymmetrical tonic neck reflex and the positive support. The asymmetrical tonic neck reflex we already described. The positive support is a reflex which occurs when you move forward in weight bearing onto the ball of your foot. And what happens with a patient is this, we all have this. We'll all tend to go up on our toes, but if we have normal tone, we will step out of that to keep our balance. Patient, however, cannot do that. It becomes an exaggerated reflex. And tonic, that's a good description there for abnormal. And they get locked into extension and can't maintain their balance. And it really is a wave of extension that really shoots up the whole body from the foot. With head-injured patients, this can be much more of a problem than it is with stroke patients. And they can have a much greater variety of tonic reflexes. Symmetrical tonic neck reflex, grasp reflexes, the tonic labyrinthine reflex, and they usually have them in more in number, and they're usually stronger because of the fact that the lesion generally is in a different area of the brain. In any case, in treatment, we attempt, as I said, that early infants naturally do. We as therapists have to really help to integrate these as soon as possible. And the earlier you can do that, almost before they start, so to speak, the easier it's going to be. Because once a patient gets locked into this, it becomes very difficult to integrate these kinds of movement patterns. Some other movement patterns were described by the Bow baths, and they call them associated reactions. Those are terms which just describe abnormal synergies or abnormal patterns that patients have that occur with stress or increased effort or overuse of less involved parts of their body. And what happens when this occurs is their affected arm or their affected leg or the affected side of their trunk will go into one of these abnormal patterns. And they really don't have control over this, and it will interfere with normal function. Now, you and I have movement patterns that are similar to this that we call associated movements. If you're doing something that's very difficult with hand function, for example, and you're using your right hand and you're concentrating, well, your left arm may start to move. But in normal individuals, that will not interfere with function, and you can stop it at will. Boris Becker is notorious for having a tongue movement that he does when he serves, you see, and I'm sure his serve wouldn't go in if he didn't have that associated
the
movement.
Becker reaction,
Might
right?
be hard to get that to stop. But it's also important to integrate these, and one way that really helps in doing that is with a stroke patient, for example, to not let them overuse their uninvolved side, because then they'll get this overflow into their involved side and these abnormal patterns that we call associated reactions.
Okay. Now, we all have times when we're upset or nervous or whatever, when we don't move as smoothly as we usually do. Is that phenomenon related to what's happening with these patients?
Yes, you get a much more exaggerated response with these patients. If they're emotionally upset, then their tone is usually much more severely involved. If it's high tone, they're much stiffer. If they have ataxia, that they have the variations in movement are much more strong.
Yeah.
There are other factors which also make that worse, and those are if they have pain. Sometimes they will have more problems with their tone. If they work too hard, and that's another reason why we try to make things easier for them so that they don't have to put forth quite so much effort, because that makes their tone worse and their associated reactions worse. If they concentrate a lot, or even if they're fatigued, and we notice that with patients sometimes, is we're working with them and they're doing very nicely, and then all of a sudden things begin to deteriorate and you can't control their tone as well, then it's time to stop and let them rest a minute before you start again. It doesn't take a lot of rest, but you realize that you're not going to get the quality that you need. So there are many factors that can make their tone worse, and it's important to be aware of that.
Okay. Now, what about, continuing with our review here, what about problems with sensation and body awareness? Jan?
As all of us know as therapists, and I think it's important here to kind of comment on the fact that these are things that we all know as therapists. but we're just kind of going through them to show how we, with this approach, tend to address some of these problems. But they have a lot of sensory problems. Vision can be a big problem, and all of us are familiar with hemianopsia and the loss of one half of the visual field, and how that can interfere a lot with the person's orientation in space and their control of their body generally, and their trunk specifically. And problems with hearing. I think with audition, the sense of hearing, it's really important to think about the fact that most of these patients probably have more trouble with putting things together perceptually with that input.
Yeah.
They can hear, and I think most of the time understand and comprehend fairly well, but then the processing is really involved somewhere along the line because of the lesion, and they can't respond that well to verbal input. And when we talk to patients, which we do very automatically, we all talk to each other and communicate that way. I think it's very important to realize that both hearing and vision are very cortical senses, or senses that are more involved with our intellect and our language abilities, our communication skills. They're also senses in the central nervous system that require a lot of processing. They're very complex systems, which means there's a time element involved in that processing. And when a patient has a lesion, the time element it becomes delayed or slower. So we need to learn to wait for responses, especially with verbal input.
And you're talking about the cortical processing as opposed to the subcortical kinds of...
That's right. She's getting good with her
That's
terminology here. This is the area I like to talk about.
Yeah.
Getting into proprioception as an area that's involved sometimes as a sensory deficit gets us into looking at cortical versus subcortical components of function. I think it's important to realize, first of all, proprioception is our ability to know where things are in space, static position sense in joints as an example, or kinesthetic sense to know about movement. And we really know about these senses on two levels. There's a level at which we can intellectualize about it and explain it or indicate through speech and communication that we feel something. But there's another level that I call the subcortical level of processing that's involved with movement sense particularly. And most of that is accomplished in terms of sensory motor integration at subcortical levels. It's more automatic. We don't have to necessarily indicate that we know about it intellectually. So that when we test sensation in patients, our emphasis generally in the past has been on testing the more cortical senses so that they can indicate to us intellectually what they're feeling.
Sure.
And this is fairly easy because it's a very objective test. But I think we also need to learn to observe the way people move and the way they function in their trunk and their whole body, and draw some conclusions about the subcortical processing that may be going on. And most of the time with both stroke patients and particularly head injury patients, these pathways in the nervous system are still intact. And generally speaking, they have the potential to process this input. However, the tone, the abnormal tone, can mask this, so that a real key to dealing with the sensory deficits is dealing with the tone problems in patients. And once you resolve some of the tone problems, many times you can see that they really do have good sensation or better sensation than you might have thought, especially in the area of proprioception. Now, tactile sensation is a little different. What you feel on the surface of your skin, especially with stroke patients who have lesions in certain parts of their brain. They may have a loss here, and it may ultimately interfere with some especially higher level hand functions. But again, we still approach this as a sensory system that's related to tone. And through weight bearing and movement over the base of support and a lot of the components that we've talked about, it's possible for patients to become better in terms of sensation.
Okay. Now, often when we think about stroke patients and head injury patients too, we think of hemiplegia with one side of the body involved and the other side uninvolved. But that's not really always the case, is it?
That's right. That gets back to the nervous system.
Uh-huh.
It's a bilateral system. All of us know that, practically speaking. I mean, you know that your body works as an integrative whole. Both sides of your trunk, both arms, both legs, both eyes, both ears, so that it functions on that basis. And so if something happens on one side of the brain, it will not only affect the side that's directly controlled in that situation, but it will also affect the so-called uninvolved side, or what we in the past may have called the normal side, okay? So that the patients don't have this normal interplay between the two sides of their trunk and their body generally. An example of that is to look at a stroke patient and how they tend to lose their balance. They will tend to fall toward their affected side, generally. Now, based on what we saw in the earlier videotape with an early subject weight shifting laterally, it's obvious that the side of the trunk that you're falling away from is the side that will bring you back to the midline.
Mm-hmm.
Well, if this is the so-called normal side, then it should operate normally, but it doesn't.
And it doesn't. Yeah.
So that the messages are confused. And our emphasis in this approach is not to overemphasize either side. Traditionally, as therapists, we emphasized helping the patient overcompensate with their uninvolved side. Mm-hmm. Then the pendulum swung the other way, and with this approach and many others, we started overemphasizing the affected side. And now we've come around to a more equal emphasis, the integration between the two sides, which really gets back to the nature of the way the nervous system operates in the first place.
Maybe it would help if instead of saying involved and uninvolved sides, if we changed our vocabulary to say involved and less involved sides. Maybe that would give us a little verbal cue to the kinds of things we ought to be remembering. All right, let's now take a look at the first of two videotapes of assessment and treatment of people with some of the trunk mobility and control problems that we've been alluding to. As we mentioned in the workbook, there are histories about both patients we'll be seeing. We hope you've had a chance to read on page 9 the first of those, the one about Dick. If not, you will want to read it when you can. Meantime, Jan, will you just briefly sketch out Dick's history for us and tell us about anything else that you want us to keep in mind as we watch?
Okay. Dick is 47 years old and had his stroke in the spring of '86 and has bilateral involvement. He was a bilateral CVA. Mm-hmm. On one side, he has a lot of problems on the right side with ataxia, which we've already talked about earlier. And on the left side, he has a lot of involvement proximally, but a little bit better movement distally. Okay. His best function is in his left arm, which he tends to overuse, and that really throws him off. Mm-hmm. I think it's important for people to have in mind as they look at this, that this man really had no balance in sitting. He relied on the support of the wheelchair, basically. He could come away from the back of the chair, but he could not sit up straight and make postural adjustments in sitting without tending to fall.
Tell us what your goals were for this patient.
Well, his goals were easy because they were very basic, back to the basic components. He really had very little appreciation for the midline. Mm-hmm. He did not have a balance of tone in his trunk. He could not move well over the base of support. He didn't use his limbs appropriately, what he could use. And he had problems using his head, overusing that part, instead of using his trunk.
Now, these are not the goals that some therapists might have set for this patient.
Right.
These are not the traditional goals.
And yet, these are the things that will make the difference in all of his functions, as you can see as we move into some functions in the tape.
Absolutely. They become stunningly clear. All right, thanks, Jen. Now, we will be seeing and hearing you on tape with the patient, and as I understand it, we will also hear Bo commenting off camera. Let's watch.
Okay, Dick, the first thing I'm going to do is just adjust your feet a little bit. I'm going to let you move your left one. That's it. That's good. And the right one, just a little. That's good. Now don't move them. Let him stay right there. And I want your arm resting on the table. That's it. Good. Okay, now I want you to very slowly just sit up a little straighter in your back. Now I may talk explaining some since people can't really feel what I feel directly, the people who are watching us. But I want to look at your tone first and just get an idea about the way you move and what some of your problems may be, as well as what some of your abilities are, okay?
Okay.
It's important to look at the positive things too, right?
Yeah.
Okay. I'll sit up a little straighter. Now he has he sits up straight, which is important, a very positive thing, but he does have some limited range in the pelvis, because you can see, now just slump a little bit, that he tends to use primarily his shoulders and his upper trunk to come up straight. Now come from your low back. Just sit up tall. That's it. That's it. That's better. So that he's going to need a little bit of mobilization in the lower trunk and the low back. But before I do that, I would like to move him toward the edge of the chair. Now, don't do anything yet. Just stay tall. Okay? Now, I'm going to unbutton your shirt right here so I can put my head against your chest. Okay?
Okay.
Just to stabilize you a little bit. Now, no, don't move. Now just stay tall, and relax your left shoulder. That's it. It's okay. It's okay. Now go to the left a little bit with your shoulders. Not quite so much. Just your shoulders. Like that. All right? Just stay right there. Okay. That's it. I'm going to help you a little bit in your back. Okay. Now we're going to shift just a little bit toward your right side. So you shift your trunk a little. That's too much. Stay tall. Get your shoulder relaxed on the left. Get your head up. That's it. Now stay tall. That's it. A little bit to the right. That's enough. Up straight, head up. Okay. I'm going to move your left hip forward just a little. That's it. Stay up straight. Okay, head up. Shoulders up. Now we're going to shift to the left. Stay tall. That's good. Now stay right there. Stay there. Stay. Shoulders to the left. Good. And we're going to move the right hip forward a little bit. Stay up straight. Okay. And put your hand back on your knee a little bit. Head up. Head up. See, I can see you up there even though I'm looking down. Now, up straight. Easy. Shift to the right a little bit. That's enough. Don't push with that arm. Let your left arm relax a little bit. Stay up tall. From your low back. No, no. Let me help you with it. That's it. That's it. Good.
His tendency is to push with his left arm to keep himself straight rather than using his low back muscles.
Shoulders to the left a little. No, the other way. That's it. Good. Good. Now, stay up tall. Relax your left arm a little bit. That's it. Okay. I'm going to mobilize your low back just a little bit. Okay? Dick?
Okay.
Okay. Up straight. No, you're pushing. That's it. Okay. Now I want you to sit up tall. That's it. You feel that in your low back?
I think.
Good. Now I want you to slump a little bit. Slump. And move your pelvis back. That's it. Good. And then we're going to come up straight again. Up straight again. Easy.
And she's helping him extend his lower back and not push with his arm, so that he moves his pelvis rather than his shoulders.
You're okay. And you can see that he has a lot of trouble keeping the right arm, hand on his leg, and keeping the right arm under control. And that's something you want to watch through the session to see how it improves as his trunk improves. Now a little taller, easy, shoulders left. That's it. That's it. Okay, chin down just a little. Shoulders left. Good. That's it. It's better. Now I want you to slump. Let your hips just roll back. Easy. Okay. And then come up tall. Good. A lot better movement of your pelvis and your low trunk. And slump. Okay. Now just stay right there. This side's got to go too. Okay. Now come up tall. Chin down a little bit. That's it. Now stay right there. Stay there. Up tall. That's it. And one of the things that's really important here is to get him to stabilize on the midline, because basically the component of midline orientation is a component that he has a lot of trouble with. So just to get him to know where the midline is, where that center is that we talked about. Now sit up tall. Good. Much better. Good. Just open your hand. Easy. Not too much. Don't work too hard. It's very important that he doesn't put excessive effort into things, because of the fact that his tone becomes much more difficult to control if he works too hard. Ease of movement is critical. Stay right where you are. I know how hard it is.
Thank
You do too.
Yeah.
He's had to work really hard to compensate for a lot of his problems. And the idea is to get him to tone down where he tends to overcompensate, which is primarily on his left side, and to get him to use the right side in a more integrated way with the left side. And he really lacks that integration between the two sides. Okay, that's very good what you're doing right now. You've stayed on the midline for quite a while here. Now, what I want you to do is just keep your back straight. That's good. And just bend straight toward me from your waist. Keep your head up. Look straight ahead. That's it. That's enough. Now stay right there. That's it. Straighten your back a little more. Good. And then you're going to go back where you started from to sit back a little bit. That's it. Okay. Up straight. Too much. He also needs to learn to grade his movements. He moves the right direction, but he tends to move too much. Now very slowly, up a little taller. That's it. Good. Now stay that way and bend straight toward me. Now stop right there. Bring your shoulders to the left a little bit. Stay tall. Good. And then sit back, but to keep your back straight. Head down a little bit. That's it. Again, you can see his tendency to use the head a lot to initiate the movements that should be initiated from his lower trunk. Okay, up a little straighter. Now he's pushing a lot less with his left arm, that's really good. Now stay tall. Good. A little taller. That's it. All right, now, nice and slow. Now shift a little bit to your left. Stay tall. Chin down a little bit. That's good. Now stay right there. Okay, stay there. I want you to move your right hip forward a little bit. Good. Stay up straight. Open your hand a little bit. That's it. A little. Relax. Relax. And straighten your back a little bit. Easy. Now, stay right there. Shoulders to the left a little bit. Left. Good. Don't worry about left and right. Everybody gets it mixed up. We all do that. A little straighter in your back. That's good. All right. Now, I'm going to shift a little bit to your right. Slowly. Don't lean. Let me help you with it. No, just let me help you and move with me. Just sit up a little straighter. Okay. Stay tall, up straight. You need a little more shift to your right side. That's good, that's good. Up tall. Stay there, stay there. And then back to the middle, okay? Stay up straight. To the right.
Now she's working on weight shift to the right, maintaining elongation on the right side,
Keep your back straight.
which is difficult for him. He tends to move his shoulders to the right.
Okay, now just move with me. That's it. Good. Now, a little taller from your low back. That's right. You feel that? Just tune into that feeling. You did exactly the right thing. Now, I'm going to move your feet, help you move your feet a little bit, but just wait. Just stay. Don't lean back. Straighten your back a little bit. That's right. All right. Now we'll just bring the left one forward a little, and then the right one. Keep your back straight. Good. I also think everybody needs to appreciate how much work it is for you to hold like that. Working your trunk's hard work. Look at me. That's it. A little straighter. Good. Now, I want you to stay there. And I'm going to move your arm around a little bit. And I don't want you to help a lot. I want to get a feeling for what your tone is like. Okay? Now, he helps. Straight back. It's very important for him to keep his trunk. You're fine, you're fine. Just stay to the left a little bit. Only stay up straight. That's it. I bet you thought your mother was the last one that would make you do that, didn't you? Now your therapist does it. Straighten your back a little bit. Good. A little bit of resistance when the arm is to horizontal, which generally indicates a little bit of stiffness in the trunk. See, right about there, I feel a little. It's hard to move from there for you.
No, I think.
Does your arm feel heavy to you?
No, I think.
Just hard to control.
Yeah.
Straighten your back a little bit. That's it. Chin down a little. Good. Elbow feels good. He can move with me at the elbow. And what you're looking for here is how much tone he has that's within normal ranges. If he assists, which is natural for people to do as you move them, they move with you, which he does at the shoulder and the elbow. It's harder for him to do in the wrist and the hand. And there's resistance to opening the hand, which means he's got a little higher tone in his flexors. I'll come up a little taller. That's it. Okay, now just stay right there. Keep that hand there, can you? Or is it better here?
Where?
On my leg.
On your leg.
Okay. Straighten your back up a little bit. That's it. Good. Now, I'm going to shift you a little bit to your right. Good. That's 100% better. Just keep your hand on my knee. Stay tall. I'm going to move your left hip forward. Stay up straight. That's it. Good. Easy. Shoulders left just a little. That's it. Stay up straight.
In preparation for the transfer, Jan is bringing Dick closer to the edge of the chair.
Easy. Now we're going to shift a little to the left. Just move with me. That's it. That's all right. Wait. Don't hold tight to do that. You're fine. I'll go around your arm. Relax your left arm a little bit. That's it. Now straighten your back a little more. That's it. Stay to the left. Stay tall. Good. And then we'll move your right hip forward. Good. Up straight. Straight. Easy. No, come forward. You're all right. I shouldn't have said it so loud.
No.
Now straighten your back a little bit. Put your right hand back on the table. You're all right. Now, stay right where you are. Now just straighten your back a little bit. Easy. That's it. Shoulders to the left a little. That's better. Good. Straighten your back a little more. Good. You got it back. It's important to work through those problems. You're not going to always get it right, all right? You listening?
Yeah.
Good. Now just move with me. That's it. Stay where you are. That's it. A little taller. That's it. Stay left, to the right, excuse me. That's good. Stay right there. A little taller. Good.
You notice he maintains his back more erect.
That was great. You're getting 100% easier to move, which means you're doing more and you're getting better. You got that?
Well, it seemed easier just to give up and go over.
What I'm going to try to do is get you to exercise your leg a little more.
You're good.
And I'm going to move your feet a little. Oops. Okay, now straighten your back up a little bit. Good. Now, all I'm going to do is just bring this hip forward a little more, and then we'll go over, okay? Keep your back a little straighter. Nice. Okay. This is just a way, Dick, of getting you to really use your back more and to use your legs more for a longer period of time, which is a way of exercising them, okay? That's it. Good. Go straight. Wait. Just straighten your back up a little bit. That's good. Stay right there. I'm going to turn this one first. I'm turning his feet so that he can move and not get them all twisted, since these soles don't move real well on the rug. Makes it a little easier for you. Okay? Now this time, straighten your back up a little bit.
The foot adjustment is putting the right foot a little further ahead of the left. You always have the foot toward which the patient is shifting slightly ahead of the opposite foot.
Stay tall. Good. Now you see the table, right? Mm-hmm. Okay, now wait. We're not going to go fast. Just stay tall. That's right. Now I'm going to still use my head where I had it before, okay? Weird, but okay, huh? Stay where you are. Now this time, wait, stay up straight. Okay.
It's important for him to keep his back straight as he comes forward at the hips so that he uses his legs to lift with.
Stay up straight. Easy, easy. Stay to the left with your shoulders just a little. Good. Stay back a little. Nice. Shoulders left slightly. Good. Now, this arm, just leave your hand where it is on the right, okay? Because it'll be better there as you transfer. You're not going to stand up. You're just going to kind of pivot over. You know what I'm saying?
Yeah.
Okay. Now keep your back up a little straighter. Good. And bend forward. Keep your back straight. Okay? And come back up straight. Good. Okay, wait. Don't worry too much about your right arm. Straighten your back a little bit.
She's trying to keep his right arm in a position of weight bearing.
Good. Shoulders to the left slightly. Slightly. No, that's too much. That's good. All right. Okay. Now bend forward with me. Okay. And I want you to push with your legs. No, keep your head up. Keep your back straight. Good. I want you to push with your legs and put your bottom over on the table. Keep your head up. Can you push? That's okay. Just wait. Come back up straight. Okay, I'm going to change one thing. Stay tall. Just stay up straight right there. A little taller. Okay. You're going to push like you're going to stand up. But you're not going to stand all the way up. Okay?
Okay.
Okay. Keep your back a little straighter. Okay. Now just bend forward. Keep your head up. Just keep looking straight ahead. Okay. Let's push like you're going to stand up. And come over onto the table. Stay right where you are. Stay where you are. Wait. Just stay. I've got to move your legs. So just stay right where you are against me. Okay? Now wait. Okay. I'm going to move just a little bit your left foot. Oops. Okay, now back a little. That's good. All right.
She gets him to help do the things that he can do while she helps him control the rest of his body. This teaches him how to do the transfer while you're working with him.
I've got you. Just relax your left arm. Now look up. Okay. Straighten your back a little bit. No, wait.
This particular type of transfer is more normal than the types of pivot transfers that we often teach patients.
You're okay. Now straighten your back up. Sit back. Good. You did all right.
Am I allowed to say something?
Yes, you're allowed to say anything you'd like to say.
What therapist is going to take this long to transfer? Tell me that.
Well, some therapists may take this long, and what we've done here has taken us about 10, 15 minutes. That may be what's done in a session. But if you learn that, then you've got it. Then you don't have to practice it over and over again. You see what I'm saying? Because you've taken the time to spend in one situation. That's the only way you're really going to learn it again. If you go so fast with everything, you won't learn the control you need. But that means that you don't have to spend 2 weeks working on the same activity. You see what I'm saying? I'm sure that you spent lots of weeks working on the same activities.
Yeah.
Well, one reason that happens is because you never really get it with the control you need. So you just you do it, and you're capable of doing it, but you don't do it with using this side as much as you need to. So you continue not to use that side. And this way you actually get better faster sometimes, because you don't have to do something over and over and over again.
Okay.
Does that make sense? It works.
I'm believing you.
Now bring your shoulders back a little. Good. What I want to look at now is just asking you to move a little bit and seeing what your control is like. All right?
Okay.
All right. Now I want you to slump a little. Wait, that's right. I just need to wait for you, don't I? And then I want you to come up straight. Good.
You notice there that he moved his pelvis more than his shoulders when he came up straight.
Okay, now slump slowly. Let your hips roll back on the surface. That's right. That's right. Watch your knee. And then come up straight. And I'm not going to hold you. That's it. Good.
He kept his alignment much better that time.
Relax your left arm a little bit. Good. Straighten your back a little more. Bring your shoulders to the left a little. Now, I'm going to help you a little bit to shift to the side, okay?
What side?
We'll come toward me first. Only stay tall when you do it. That's right. Good. And then back to the center. Stay up. Shoulders left a little bit. Toward me. That's it. Stay tall. And then we're going to go to the right a little bit. Okay, now on this one, move with me, okay? Just feel what my hand is doing and move with me from your back. Stay tall. Bring your head toward me a little bit and look straight ahead. That's it. Now sit up a little straighter. Straighter. That's it. Good. Now sit back a little so you're not leaning forward so much. That's it. Okay, now I want you to just bend forward just a little from your waist. A little more. Straighten your back a little bit right there. Good. Keep your shoulders toward me a little more. That's it. And come back up straight. So you sit back. Not too far, not too far. Straighten your back up a little bit. Good. Bring your shoulders toward me a little bit. Okay, now just bend forward. Good. And right there, stop and straighten your back a little bit. Nice. And then come back toward me. So you sit back. Good. Once more. Stay tall first. That's right. Keep your right knee in a little bit. That's good. That's enough. It's really important that he be able to move the legs around and stabilize in his trunk as well. Okay, now straighten your back a little bit. Good. And keep your shoulders toward me a little. That's right. Now, shoulders back a little. Good. Now I want you to bend forward, but don't fall. Now stop right there. Stop. And straighten your back a little bit. That's it. And come back up straight.
He's keeping his shoulders aligned over his hips and keeping his back straight and learning to move on the midline.
Move your hand forward on the table just a little. That's it. That's enough. And then move it back toward you slowly. And keep your back straight when you do it. And let it down on the table. Okay. Straighten your back a little more. Good. Now move your hand forward on the table. That's it. Now stop right there. Let your elbow. And then just bring your hand back a little. Good. I want them to see how much better your arm moves. It's just a little better. Your hand, now let it rest on the table. That's right. Straighten your back a little more. And keep your shoulders toward me a little bit. Okay. And just stay right there. Now, keep that right knee in just a little. A little. Straighten your back a little. Now I'm going to put your hand on the table surface. Don't push. Don't push. Use your back instead. And relax your shoulder a little bit. Right here. Good. Now I want you to stay there. That's right. I'm going to move a little bit. Now stay up tall. Good. Shoulders a little to the left and straighten your back. Nice. You look 100% better. Okay.
Maintaining his own posture, using arms for support, centering his trunk between his hands.
Relax your left shoulder. Now one more shift to the left just a little. Toward me. That was a great shift to the right. It was. Up straight. Okay. Now just shift to the right. Okay, and then shift the other way. Don't lose it. Don't go too far. And come back to the middle. Nice. To the middle. That's right. You're finding that a lot better.
Yes,
Now come up.
It's because it's soft.
That's right. Now come a little bit to the left toward me. Stay tall. Good. And then a little bit the other direction. Stay tall, though. That's right. And then come back to the middle. And bring your shoulders in good alignment. That means you need to come back a little bit. Not too far. Good. Slightly toward me, and then we'll stop. Slightly to the left. And sit up real straight right there with your shoulders back. Shoulders back. Good. Good work.
Thank you.
Don't. You're doing fine. You need to be able to talk and hold that now at the same time.
Yeah.
Yeah. I enjoyed working with you,
Thank you. I enjoyed working with you.
and we thank you for helping us.
But you did all the work.
No, there's no way I could do that. You're too tall for me.
I would just like the therapist to be like her and take her time with people like me because we do not enjoy being in this situation.
This concludes the clinical update presentation of Dysfunction of Trunk Mobility and Control, which featured Isabel Bowman and Jan Utley. For more information about Clinical Update or any of Aaron's educational programs, call or write the American Rehabilitation Educational Network.